Okay, welcome everybody to my live. In this live, I would like to discuss Empyema. Okay, so what is Empyema? So let's say, for example, someone have a pneumonia. There's an infection in the lungs, right? And a pneumonia can essentially lead to a pleural effusion in which there is so much buildup of the immune cells, and too much of it can basically that pressure it can make the infection, the inflammation can make the vessels increase in the permeability of the pulmonary capillaries, and that can lead to leakage of the immune cells into the pleural space, and that can lead to an empyema. Okay, so looking at the causes, let me just see if I am sharing my screen. Okay, cool. I am sharing it. So essentially, the causes of empyema, right? So you have infective causes and you have non-infective causes. Okay. Now, let's see. Infective causes. The first one is that of a bacterial pneumonia, right? And the common pathogens. So there are four common pathogens, right? You have strep pneumonia. You have Staphylococcus aureus, including the MRSA. You have Streptococcus pyogenes, and you have the Haemophilus influenza. Okay, TB is also very quite high on the list for empyema, and then post-surgical or post-traumatic, right? So post-surgery or trauma. Non-infective causes, so underlying medical conditions like immunodeficiency, so HIV, cystic fibrosis, right? Congenital heart disease can lead to an empyema or rather predispose children to infections that leads to the empyema. Okay, now the pathophysiology. So you have the initial infection, and then what happens, as I spoke about earlier on, there's the increase in the exudate which occurs, and then you have it goes into the pleural space. Now, fibrin deposition when occurs, and the pleural space, the pleural fluid becomes purulent as neutrophils migrate into the pleural space, and then fibroblasts proliferate, leading to thickening of the pleura and formation of the fibrous peel, okay, which can trap the lung and inhibit its expansion. That's why I have an increase in the work of breathing as well. And there's a whole microbial action of the bacteria that occurs. Complications of empyema. So there's the respiratory complications as well as systemic and chronic complications. Okay, so respiratory, systemic, and chronic. All right. The respiratory complications is these three branches under there. You have lung entrapment, right? And this refers to fibrosis and thickening of the pleura, and it can prevent full expansion of the lung and lead to a restrictive lung disease. It can lead to a pneumothorax, um, as well as a bronchopleural fistula. Okay, so which is abnormal connection between the bronchial tree as well as pleural space, indicating infection. Systemic complications include sepsis, okay, and it can cause something SI or is systemic inflammatory response syndrome, as well as multi-organ failure, respiratory failure, okay, compromising function in mechanical ventilation, as well as malnutrition and loss of weight. Okay, uh, chronic empyema can occur, and then pleural thickening can also occur, right? And then also developmental delays as well. Now, on history, right up. So, on history, you have a whole list of symptoms which can occur, right? So, those include fever indicating infection, a cough indicating also respiratory infection. So, dyspnea, increase in the work of breathing, a recent pneumonia or a recent respiratory infection, underlying conditions such as cystic fibrosis, HIV, or any immunodeficiency disorder, congenital heart disease, or a chronic lung disease can increase your risk of also developing um, a empyema. Progressive respiratory distress, so respiratory distress, worsening cough, increase in the work of breathing, right? Increase in the work of breathing and fatigue. So that is more in terms of the progression of the symptoms, right? You then get failure to improve, so lack of deterioration despite this lack of improvement despite antibiotic therapy, and then you have a lot of physical findings. Now, the physical findings I'm discussing in a moment. Just some things I need to mention on symptoms. Pleural symptoms. So the child, older children, can present with pleuritic chest pain, right? And a pleuritic chest pain happens when pain while coughing. Okay. Um, Malaise, poor appetite, weight loss, right? All of these things, loss of weight, loss of appetite, signs of sepsis, lethargy, poor perfusion, right? All of these symptoms, right? Was there any exposure history? Or with TB exposure? Okay. Now, in terms of respiratory signs, so on presentation, right now. So on presentation, we have respiratory distress. So you have your subcostal recessions, intercostal recessions, alar flare, head popping, or tracheal tongue. Um, you can also have grunting as well, and then increase in the respiratory rate. Yeah. Patients can also have a fever, we spoke about that, and on a general exam, they might also be cynosed. Politic chest pain for children who are able to, for the older children, and signs of systemic illness, right? Spoke about the malaise, poor feeding, weight loss, lethargy, poor perfusion. Okay, so poor perfusion in more severe cases. Okay, we spoke about that, and then decrease on respiratory exam. There is decreased breath sounds, so decrease in breath sounds because decrease or absent, right? So the absent or decreased breath sounds over the affected due to the consolidation. Then there's definitely be some crackles for indicating the fluid in the alveoli, and also bronchial breath sounds, right? Or bronchial breathing. In terms of percussion, you have dullness on percussion. So pleural causes a shift in resonance from normal resonance to dullness over the area of fluid accumulation. It's a classical finding in empyema. You then have, in terms of the expansion, there's a decrease in expansion. So decreased in chest expansion because of the buildup of all that fluid. Spoke about respiratory distress, spoke about all the other signs and that. Okay, in terms of investigation, so in terms of the investigations, chest X-ray, gold standard, right? So there could be a blunting of the costophrenic angle. So Okay, highlighting of um, orthophrenic angle, homogeneous opacity in the lower lung fields. So homogeneous opacity of lower lobes, right? So lower lung fields, and then the meniscus sign indicating the fluid level. Okay, so you have a meniscus sign as well. The ultrasound is essentially to confirm the presence of the pleural fluid and demonstrate free flowing and blocked fusions. Not talking too much about that one. Okay, so can have an ultrasound as well. And then CT essentially for detailed visualization of the pleural fluid. Now blood tests, so obviously you have your FBC for the white cell count, you have your CRP for the infection, and also you want to do a blood culture to define the positive organism, right? Especially in a child that is septic. Then for the fluid, we're going to do a thoracentesis, especially looking at the appearance. Is it turbid or purulent? Which suggests the turbulent or pus, which suggests the empyema, right? So the biochemical analysis shows high protein. So high protein, high LDH, low glucose, as well as a low pH, right? In Urdu, part of the thesis, you would also do a gram stain culture and sensitivity, right? So gram stain and culture to identify the causative organism, okay? And in cytology, you could also do as well to rule out malignant cells. That's cytology. Now, the sputum culture, if the child can produce the sputum, so with the coughing of the sputum, you can do a sputum culture. You can do nasal swabs and PCR testing as well, especially if it's any viral infection. Okay, and then for TB, we do the VEN2. Okay, do the VEN2. So obviously more than 10 millimeters is indicative. Bronchoscopy is any foreign body aspiration. Okay, and then an echo if there is any pericardial effusion or underlying um, cardiac problems. Okay, so plus minus ECG, and then yeah, okay, that is good. Now, in terms of the management, so empirical antibiotics is very, very important, especially in the case of infection. So, common choices include the combination of the beta lactam, example, ceftriaxone or ceftaxime. So, in terms of antibiotic, you have Kef or Kefo plus a Zithro or the Vanco or clindamycin, right? Plus a Zithro or Vanco or clindamycin, which covers the MRSA, the methicillin-resistant um, methicillin, methicillin, methicillin resistant Staphylococcus aureus coverage, right? You can have a culture guide antibiotic, that's important. But if you don't get a culture, you must still initiate antibiotic therapy. Drainage of pleural fluid, so thoracentesis to relieve symptoms, right? Thoracentesis, a chest tube, right, for larger effusions, interpleural fibrinolytic therapy. Okay. Could also be some surgical interventions or an open thoracotomy or visual assisted endoscopic surgery is essential. Supportive care, oxygen is essential, analgesia as well as hydration plus nutrition is really, really important. And then also some physio as well. Okay. Regular monitoring, imaging, chest x-rays, bloods, and then immune status, manage any comorbidities such as cystic fibrosis or disease or any other chronic illness, malignancies or immuno deficiencies. Over here, you can see for some images, you can see that is your pleural effusion over there, and this is also showing pleural effusion, or rather the empyema. Okay, and that's it, everybody, for the session on empyema.